Hormonal evaluation, male and female is important. And coming to the male, 4 friends. LH has got, so this is the way things are moving, and I'll try to make it more simple as I move ahead because this is a very important topic.
But it will change the taste.
I know. There are no Sertoli cells, no Leydig cells. This compartment is gone. And when this compartment goes off, what small testes, this is very important concept. Please be with me. Small testes increase. You took the pledge with me that we'll keep learning. So learning on the Independence Day also. They gave me a challenge. It can't happen on Independence Day. But thank you so much for doing in the body all half the time. And we are trying to find out about LH. We still don't know. It is out. We get corpus luteum formed, and that will secrete progesterone. And progesterone will be in control for next 14 days. E2 keeps building up. Then E2 comes down, and progesterone, which was around less than 1, goes up to. Research is the one, in case you say what to avoid in the IVF. Coming to the part 2, in case we have any problem with the LH, natural peak means 48 hours. It's a crazy concept to understand, but I want progesterone endocrinology. This is very important. P4 is always very confusing. It's always very confusing. So I'll talk about P4. P4 is always very confusing. It's always very confusing. So I'll talk about P4. So P4 secretion is a part of 2-cell theory in the female. Progesterone comes whenever the LH is rising.
Which is better, sir, HCG or GnRH for treatment?
It depends upon we use whenever we use LH, whenever we use GnRH agonist. Whenever we use GnRH agonist, we have to go in for a freeze-all because it can harm the endometrium. So whenever we use GnRH agonist, we have to do freezing. Just remember that. Ideal way is freezing. So I always prefer in IVF agonist for all. In IVF, antagonist cycle, agonist for all, freeze all. This is my take. Somebody's take may differ. This is my take, and it works pretty well. And this is working all across the world. Whenever we give a GnRH agonist as a trigger, freeze all. In IUI cycles, what we do is that we can't trigger with agonist because endometrium will be bad. So in IUI cycles, trigger with HCG, recombinant HCG.
Okay. Thank you.
Welcome anytime. And I'll encourage, in case someone wants to know anything, keep talking. So premature. So as the
ideal dose of HCG, sir.
One sec. Let me complete this slide first. I lose my mind. It's a very important slide. This is the whole crux of teaching you today on a Sunday morning was to talk about this particular slide. So please please switch on your mics, all of you. A lot of noise is coming from behind. I request to switch yourself off. So when the LH peaks goes high, along with this, your P4 will also go high. So before ovulation, the P4 may be high. Just remember that. This is part of the normal LH peak that P4 comes. So now when we look at the premature rise of P4, 35% of cycles of AP and LP have got chance that the people would be having premature rise of P4. That's called premature rise of P4. And this is what we want to avoid all the time. This is we want to avoid. This is what we avoid actually all the time. We want to avoid premature rise of P4. But it happens. You can't avoid it. Premature elevation of progesterone. We call it as PMEP. is to be compared with PML, that is called premature luteinization. This will occur after we have corpus luteum formation earlier. But this occurs as a normal surge which comes with LH. So there are two different things. This is one which is dangerous when we do IVF. Before we start an IVF freezing cycle, we have to look at P4 values, and they occur due to premature elevation of the progesterone. It's not luteinization, it's elevation. So whenever we get PMEP, we go in for freeze-all. And this is the new concept which is gradually coming in. Just remember that P4 rises 12 hours after the surge. I've told you already, and then plateaus. P4 rises again after ovulation. There are two peaks of P4 I've told you. P4 has got two peaks. Remember this. And P4 elevation is more in poor ovarian responders and endometriosis. Just remember it. And age. When the LH goes high, P4 and endometriosis will always go high too. Now, as you're moving ahead, look at these few numbers. I take hours for the classes which we hold, but here I'm just giving you some numbers. So to tell you, I can't teach you so much. Just want to tell you that these numbers are there and these numbers have to be followed. So less than 1 nanogram, 1 to 2 nanogram, more than 3, more than 10, less than 1.3. This is the one which is important. This is the one which is important for us. Pre-luteal phase support, progesterone kitna hona chahiye. Before we do start progesterones in an FET cycle, how much it should be there? Less than 1.3. If we get progesterone more than 1.3, we don't do any breathing cycle. This we have to know. And then coming to this chart, I'll skip this chart. This I've already covered for you. This is a chart about telling us about the hormones, and I'll just sum it up in a very simple way as we move ahead. That just know that estradiol is always inversely proportional to FSH. Whenever E2 is low, FSH is high, and when FSH is high, E2 is low. Just remember this. Also remember that E2 values are directly proportional to LH. When E2 is high, LH will go high in the body. And this will again be proportional to inversely to the FSH that we know. But there are some twin peaks coming. That's a different issue. And we also have to know that LH is normally high. And when LH is high, your P4 will go high. And this is equally proportional to the androgens or testosterones and directly proportional to the estradiols. So whenever all these hormones, they work together, and always remember that when any of them, they go rogue, all of them, they go rogue. So you'll find that a patient who has got raised LH will always have raised P4. They will have raised E2. They will always have raised testosterone. And this is the concept which I always tell to all of you, that our aim is to keep monitoring these things pretty well, very closely, and they occur very commonly together in PCOS and endometriosis. Just keep it in your mind. So there are some formulas. Now, as I end the class today, there are some formulas which you have to know. Sometimes you have difficulty in converting picomoles to nanograms per ml or picograms to millimoles. There are some progesterone, there are some formulas are there which you can always use, and they're available on the internet. Just go and learn from them. They work pretty well. Okay, then this is an example that in case you want to convert 1.2 nanograms of progesterone, they will get converted into 3.81 of nanomoles or high number of picomoles of 3816 of picomoles. So sometimes when you are having difficulty in understanding, download these calendars. I also do it for myself. That's it. So the thoughts I have left to you is that always have respect for LH. LH is a very rogue molecule about which we are confused. We are very confused about LH. So what I've told you are things, I think they're in the right order. You would have understood majority of the concepts, but LH is one rogue molecule, and always try to control LH, whatever we do. LH we cannot control in aged women, poor ovarian responders, and PCOS. Here they will create havoc, and as we know it, and also endometriosis. This is my observation. It can be challenged, but in my experience, it's my experience. Before, whatever I've told you till today is well researched, but this is my experience. Then you have to also know that P4 values are very critical for us, and in case we have P4 values more than 1.3, we should not carry out any embryo transfer. This I wanted to tell to you. And I think that's it about the female. And about the male, I have told you that whenever you get a male who has got increased FSH, his LH may be normal and testosterone may be normal, because LH is a very hardy cell. LH Leydig cells are very hardy cells and they don't die. They're very sturdy. On the other hand, FSH acts upon the Sertoli cells, which are very soft and they disintegrate very quickly. And I think that's it from my side. I have ended my presentation for you here today. Thank you so much for being with me. I will stop my screen sharing. I have taken 45 minutes as promised on the Independence Day. Now you can go for your flag hostings. I'm all with you now. Yes.
Can I ask one question?
Any number.
So, what are the values for TSH and prolactin you take as cutoff in primary and secondary infertility?
Ma'am, there is nothing called primary and secondary infertility, first of all. Infertility is an infertility. This is what I like to tell you. The values of TSH are always taken, cutoff is, anybody would like to take this query? Anyone from our gang? Let's see.
2.5.
Yeah, great. That's my tigers. 2.5 is the cutoff. So 2.5 is the cutoff, Dr. Anju. 2.5 will remain a cutoff in case a woman is not pregnant and wants to become pregnant, or she's pregnant. But after she delivers, the values may be touching 4.5 or 6. We don't actually, it's a different ballgame. But when she's trying to conceive, 2.5. And prolactin, anyone, what are the levels of prolactin?
Below 25, sir. Below 25.
Yeah.
5 to 25.
5 to 25 is the one which we take as normal, but sometimes some units they take as 15, but 5 to 25 is the one. After that we start treating. But remember here, how do we do prolactin? Anybody? Ideal way of doing prolactin.
Sir, 9 a.m. Two hours after getting up. Pooled sample.
Patient sample.
Pooled sample.
There is no breast stimulation before that.
Yeah, so pooled sample is important. Many times one single sample can go bad. So in case you get a single sample going bad, don't start anybody's cabergoline. Always do a pooled sample. This is important.
How many samples to be pooled?
Three. I get caught in the people because it's an expensive test. We order for a single sample. When it is normal, pata nahi, it's a debatable thing, but it's a pooled sample is required. People can't afford many times, so we say go with one. It comes abnormal, do a pooled before we put you on. But actually, prolactin you should not treat till the time you have not brought down TSH values. So TSH and prolactin are good friends. Remember that they come together. TSH and prolactin come together. So try to normalize TSH. And in case your prolactin is 25, 26, hold on for 2-3 weeks. It'll settle down.
Sir, how should we adjust the dose of cabergoline for prolactin?
Cabergoline, so normally we give 0.5 milligram tablet only. We don't titrate the dose of cabergoline. Kabhi humko zarurat nahi padta that I should go into any high values. But in infertility, if the values are more than say 200, More than 100, they go to, we send them to an endocrinologist. We don't handle them because they need better care. But for 25, 30, 40, we just put them on cabergoline and they be 0.5 milligram weekly. They become. This is what I normally do, or maybe
Weekly.
twice weekly. Yeah, weekly dose. Bromocriptine we are not using anymore.
So the
Should we stop?
picture
Should we stop when patient gets pregnant?
Yeah, it should be it is debatable. It is also said that we can continue. It doesn't cause any problem. It's up to us. But normally I like to stop cabergoline in case she stabilizes at around 14, 15 weeks. We can stop it also. So here we don't have a very clear answer. Okay, should we start or we should continue?
Thank you, sir. Thank you.
Sir, the P4 2 peaks which you told,
Yeah.
what is the significance, clinical significance?
Yeah,
that,
very important, very important, very, very important, very, very important. That's a question.
When should we add?
I'll tell you. That's a very, very beautiful question. And this is the question which you have to actually know. I can see Dr. Ruchira Notyal. A long time I have not seen you, ma'am.
Namaste, sir.
Hi, Sam. How are you? We are all lovely colors behind you. What time? 5 o'clock?
It's about 10 minutes past 5 in the morning.
I know you guys are fantastic. Thank you so much for joining us. Lovely. Good seeing you.
Hello,
So I just.
Hello, sir.
Hi, Sam.
Yes, sir. Please, you made mention of embryo transfer should not be done when the P4 is of a certain value. What's the value, sir?
I'll tell you. So this question came sometime back about the P4. So P4 values, P4 has got. So I just removed one of the delegates. Sorry for this. Okay. Now coming to P4 values. P4 values are the ones which have two peaks. जब E2 बढ़ता है तो E2 अपने साथ में LH को लेकर आता है और जब LH आता है तो LH अपने साथ में P4 को लेकर आता है. As a part of two-cell theory, simple two-cell theory. But it's a very small peak of P4 comes with LH. When the LH is rising, P4 also rises. A small peak is there. Irrelevant, but peak is there. That has got nothing to do with corpus luteum. Nothing to do with corpus luteum. It just occurs in the body. Second peak of P4 occurs after the corpus luteum is formed. So many times people say, we have not given any progesterone, we have not given any HCG. Why is the P4 high? Or we have only given estrogens. Why does the P4 goes high? But remember, हम जब भी किसी को E2 देते हैं, some level of LH will come in the body. And when LH comes, it will drag some P4 with it. So that P4 is the P4 which we use, cutoff value we use before we do the triggering. We start luteal phase support in the patient. And from Dr. Sam and the previous questionnaire, I don't taste the name, ma'am, you can come on the screen again. The cutoff is 1.3 nanograms per ml. Before you start progesterones, P4 should not be more than 1.3. Many people advise 1, but you can go to 1.3 maximum. In case P4. But remember, in the people PCOS and endometriosis, P4 values may be very high.
So, sir, in every means induced cycle, there is no need to add progesterone. It just depends upon the hormonal level.
Which cycle you're talking about?
Ovulation induction cycles. When we add the progesterone in the luteal phase and all, is it necessary to add in every?
Yeah. Dr. Darshana, this P4 formula will only work when there is a natural ovulation. When we start giving the patient, when we start giving multiple follicles, we start generating, the balance shifts, all the peaks go haywire. When we have single follicle, this formula is okay. It will support a single baby growing. But when we have multiple follicles being triggered, then we have this thing doesn't work. Whole LH will go into disarray. Whole corpus luteum will be defective. All the peaks will go bad. P4 will go bad. and P4 values go very erratic whenever we are giving the patient doing ovarian stimulation. So in case she conceives on her own, or you give her clomiphene or letrozole with a single follicle, don't give any LPS. So IUI cycles, no LPS. But when you talk about IVF, when we have multiple follicles or IUI with HMG, then we have to always give LPS.
Sir,
The role of P4
last
on
answer you
day 2
have
of
given in
menses,
endometriosis and PCOS. If P4 is raised, then what we can consider?
Cancel the cycle.
Then what we do for next cycle?
You could prepare
Sir,
her well.
sir, how to downregulate P4, sir? Then if P4 is more on day 2.
Very difficult. This is a common problem I face in endometriosis patients. I cut a very sorry figure recently. I have got 4 cases, 3 cases this year. I cut a very sorry figure. So now I do is that whenever I get a patient with gross endometriosis or PCOS, I normally I give them a khaskar for endometriosis. I give them a depot analog of 3.6 or 3.75, down-regulate them and then start their cycle.
If it still remains high, shall we transfer or no?
No. Transfer to, there is no question of transferring.
Okay, yes.
Let them get angry with you. No transferring.
Sir, hello, sir. So for how many months do you give them?
What, ma'am?
For how many months do you give them?
Depot I give only for maximum of 1 or 2 months, not more than that. But tabhi nahi hota hai, I'm not able to do it, then I send them home and tell them to come after.
After how many days of giving the depot? This leupride, we can start the stimulation.
Simple concept that you give them a depot on any day of the period. So normally we give them in the follicular phase, give them a depot, and and 21st day of the cycle, or say in case you've given it on any midday, 21st day of the depot. First of all, tell them that. Do you also remember that? Tell them that when they take the depot, they will bleed. They'll have bleeding. That's called splash and pan, because your LH-FSH will be depleted. So she'll have a secondary reserve coming out from her pituitary. She will bleed. Remember, tell her that. And then 21st day onwards, you start adding injection 0.1 milligram of decapeptyl, or you give her 1 milligram of leupride. Give it for around 7-8 days. And when she bleeds, then you do her P4 and LH, and then you can start her case. But remember, the ideal method is in such cases, I like to give them an OC pill. I give them an OC pill from second day of the period. There's one way, give OC pill on the second day of the periods, so that her she gets down-regulated on her own. And from day 21, you can start her leupride injection also. That small dose of 1 milligram.
1 milligram. So at that time, we don't need to do P4 levels?
Nothing.
That will work.
P4 will only, I don't guarantee you, Niharika. I don't guarantee you, because many cases they don't work. I've told you, the more I'm getting into these hormones now, more my life is getting complex. I don't know how many more pregnancies I'm getting. I really don't know. But my life has become hell now, because my whole life is about my juniors coming and saying, sir, P4 ye hai, ye LH hai, hum kya kare? I keep reading.
Sir, one more question. What do you do, sir, when you see a big endometriotic cyst along while you're giving stimulation? Do you deal with it before, or you?
Yeah. Always, Niharika. Give them a depot of analog before. Always give a depot of analog before, and then you start there. Do a long protocol.
Then that depot injection won't work on the big endometriosis. They won't reduce.
Nothing. You're not reducing them. You are only reducing their cytotoxins. See, endometriosis nowadays we are not removing surgically.
Yes, sir.
Stop doing surgery on endometriomas until they're coming in the way of the needle. Number 1. Number 2, in case they're very big, 5-6 centimeters, patient symptomatic hai, to nikalo. Otherwise, we leave endometriomas where they are.
But the response will be as good as the normal or the without any cyst.
No. You have to understand one thing, that endometriomas may not reduce much in size, but the endometriotic activity will reduce. Number 1.
Okay.
Size will also reduce, definitely. Not that size won't reduce size. They will shrink slightly, but they won't be angry and active. That's one thing which we do.
Once you have given depot injection.
Yeah. That's the only point. And the planes between the follicles which are there, they become better alienated. And you can do pickups easily. That's all. But in case they are coming in the way of the needle,
Yes.
there are 5 follicles lying behind the endometrioma.
Yes.
Then you have to remove the endometrioma. Then there is no way
First,
out.
you have to remove the endometrioma, then you have to go in the follicles.
Yeah, because in case, see, we don't do punctures through endometrioma.
Yes, sir. So
So
then
in
you
case-
have to change the needle, or you
One
will
question,
use the same needle.
No. You will only do this in case we got, okay, because there are 2 ovaries.
Yes.
One ovary is fine. Other
Yes.
ovary has got endometriosis. Fine.
Yes.
I'm giving a situation. So in the endometriotic ovary, the follicles are lying below the endometrioma. And in case you want to pick up that follicle, you have to go through an endometrioma in one situation.
Yes.
But other ovary is healthy.
Yes.
Then I leave the other ovary, which has got endometrioma. Ignore it.
You will leave the follicles as such.
Leave 2-3 follicles, doesn't matter. But don't operate. I won't like to
Yes.
operate upon this woman. But in case we find both the ovaries have got endometrioma, one ovary is adherent, and you can't reach the follicles at all, in that case, we have to always do cystectomy.
Cystectomy first, before giving any stimulation.
Yes. When you can't reach the follicle, we have to do cystectomy. And cystectomy should be done without cautery. Remember,
Yes.
no cautery, do AMH before and do AMH later. Always suture in case required. But don't use any cautery here.
Thank you, sir. Thank you so much.
Sir, one question, sir.
Hi,
Sir,
Aarti.
lastly,
Aarti, not seen you so many days. Where are you?
Sir,
तुम्हें देखा ही नहीं बहुत दिन से मैंने.
Sir, just one summary about,
Yes, Aarti. One check, Preeti.
sir,
One
can
check.
you,
Let me take the question from
Otherwise-
Aarti first.
females, young female who have low AMH, they have day 2 low LH also. What we can do, actually we supply them with excessive androgens, DHEA and androgens. Have they any effect on their LH?
Normally poor responders and aged women, they have some peaks of LH. Remember this. They have pH on the higher side. It's a rogue hormone. But actually, whatever you give them, there is, in one of our lectures, CRs, we had covered about adjuvants. So in the adjuvants, HFE has given very clear guidelines. See, here I'll hold on from giving my own experience, which is very limited actually. And I don't have any RCT published, so I'll keep quiet and don't talk about my experiences. But I do use such drugs once in a while. The guidelines say don't use any DHEA. We may use, it's an amber colored, but using any other drug, testosterone supplements and everything is a red color. So it's a red traffic light, but amber, DHEA is an amber light. You may use it, but androgens, it is not recommended.
Okay, sir. Sir, once we get 0.75 day 2 LH, what we should do? We shouldn't start with the cycle.
No. With 0.75 LH, it means it leads LH supplementation. No? So the elderly woman, we are giving LH supplementation.
With the
75.
HMG.
Luvaris, correct. You can, ideally, in case you have money, and you have a lot of money, you are rich people coming to you, you can start with Gonal and Luvaris. But in case of poor people, they can use HMG.
Okay, sir. HMG will work. That will.
HMG 300. HMG 300 with very, very low AMH, you can go to 300 of HMG, but not more than that. I'll appreciate 225, but HMG for poor people.
If we add 375, sir.
No. It's not advice. I've seen many people going to 375, 475. It doesn't work. Read HRA guidelines. They're very clear.
Yeah, definitely. But sir, there is, if we want to take balance between the 300 and 375, not like 450 and all, 375, and it's very tempting. It's looking, patient is not responding.
All temptations are very bad in life, Aarti.
Yeah.
You know me. We work together.
Sir, I want to ask
225, 300. Cross the karna. Okay.
Thank you very much.
So
Yes,
can you
ma'am.
just please
Shall I ask
summarize
now?
once
Yes, who's coming?
about progesterone and LH?
Sanskriti. Yes.
Yes, sir, there has been so much discussion. Just summary about it, sir.
Somebody.
Progesterone and LH, yes, sir.
Chalo, मैं बोल
About testing and
Vaman, last query, I'll take her, then I'll come to you. I'll just take her. It's a good question. It's a good question she has brought out. See, progesterone के कुछ दोस्त हैं. Some friends of progesterone are there. LH के. LH का friend है progesterone. दोस्त है E2. E2, P4, LH, and testosterone are friends. They normally work together. Remember that. LH will have a basal line. LH will go like this: 2 to 3, 2 to 3, 2 to 3. When time comes of ovulation, before ovulation, LH will go 20 times high. So from 3, it will become how much into 20? Maybe 60. After the peak settles down, we'll have ovulation. But now the problem comes that as the LH is rising, LH will pull some amount of progesterone from two-cell theory from the ovarian follicles. So LH is going high. A small progesterone is like this. Suddenly it will also show a small peak with LH peak and then go down. And then when the LH will come down and ovulation occurs and corpus luteum forms, that time P4, initially a small peak with LH surge and then high. That's the way it works. So always we are never looking for premature luteinization. That we never look because we have not given the patient any corpus, we have not formed a corpus luteum. Our main worry is premature rise, elevation of, that's called premature elevation, PME. So I've given the term PMEP, PMAP. I call it PMAP. It's not a recognized abbreviation. I call it PMAP. This is what you have to look into all the time. So PMAP going high anytime before CL is formed, more than 1.3, we should be going in for frozen embryo transfer, FET. In case FET we find, we should go in for cycle cancellation. Because PMAP goes more than 1.3, you cancel the cycle. Do it in the next cycle. Yes, Ram.
Yes, sir. One case, known case of polycystic ovaries, she had undergone PCO drilling for 4 years back.
Okay.
And she came 2 months back. At that time, her LH was 7. I had given her OC pills. Then from 31st of last month, we started stimulation. We started with 300 HMG. But follicles are not picking up. On the day of stimulation, her LH was 0.3. Then on day 6, we did, it was 0.3. Follicles are not growing in proper way. So we increased the dose to 450. And then follicles are picked up. And on day 7th, we did LH. It was again 0.3. On yesterday, we did on day 14th. Follicles are around 20 mm, but LH is again 0.3. So no antag was given. So what might be the cause, sir, for LH and what to do?
How much is the AMH of this patient? AMH kitna hai?
AMH 3.5, sir.
AMH is very good.
Yeah.
Rare to have such. Did you give any depot before for down regulation?
No, sir. No, sir. Only OC pills given.
So probably it means that this patient has got an deficiency from the top.
LH receptor problem.
Or no, LH is less. LH is not being secreted in this patient.
Yes, sir.
So LH is not being secreted.
Yeah.
I really don't know. I mean, LH is not secreting. You're giving her HMG. LH should show in the body.
Yeah.
When you,
estrogen,
I don't know.
At that time, estrogen was around 5,000 estrogen on the day 14th.
I don't have any answer because when you give somebody HMG, HMG has got LH FSH.
Yes.
That LH should show in the body.
Okay.
It's unlikely that because you're giving LH from outside, no? LH has to show.
Yeah. But it was not picking.
So this I don't have any answer. Let me have to read about it.
And yesterday, what we planned for trigger, and suddenly her IgM antibodies came positive.
Which IgM antibody?
COVID IgM antibodies.
Oh, but in case you So you have to cancel the case now.
Yeah, we cancelled, but we are totally confused what to give and what not to give.
I really don't have an answer because you're giving her such high amounts of HMG. HMG should show as LH in the body. Let me read about it. I don't have any answer. Let me read about it. I really can't take that answer.
For next cycle, I'll come with you for this case.
Definitely, but remember one thing.
Yeah.
This patient should be triggered. When LH is very low, you have to trigger her with HCG.
But sir, on each side around 30 follicles afterwards.
But in case LH is so low,
yeah,
and you trigger with LH agonist, then you'll have problem again. There will be LH won't work.
But for this much of amount of follicles, if we give HCG and she landed into some other complications, then again problem.
No, that's fine. But when LH is a hypo secretor of LH, in such case there is no reserve of LH in the body.
Yes.
What will agonist do? Agonist will take out the LH from the pituitary only, no?
But there is no LH.
Dry, then agonist won't work. This I'm sure. I'm not sure why is 0.7. I have to read about it. We'll talk about it. I can't.
But we discussed with my friend and he also advised me.
Trigger with HCG here, recombinant HCG. LH will work in this case.
Yes.
So in case of recombinant FCG stimulation,
yes, Paras.
on day 2, stimulation with recombinant FSH. And if you want to then switch over to like HMG and FSH LH, how to convert that, sir? Like initially you started with 300.
It's very simple. We normally we don't believe in 300 concept. I believe in I'm a very, very soft stimulator. I believe in 225 and 300. I'm not always in a very angry mood and aggressive mood to give hormones to a woman. It should not be given. We should never whip the ovaries. I never crossed 225 in my life.
Then how many days you'll give, sir?
For 5 days. 5 days. So for a normal responder, I'll give 225 into 5 days, 225 recombinant for 5 days, and then 300 HMG for 5 days. This is the standard protocol I've been following.
And if follicles are smaller, then you will continue for.
Then you keep continuing.
How many days, sir? Maximum.
As many. You can go for 20 days.
But sir, if we want to then make or like switch over from recombinant FSH to plain HMG, how to convert that, sir? Is there any formula or anything?
No formula. 225 or 300. Everyone will give you their own formulas, but my formula has worked over past 18 years and around 17,000 cycles.
For all cases, you give recombinant FSH?
No. I'm telling you my formula, but many people do with HMG only. So use HMG. HMG is okay. But I'm saying that what I am doing, I am giving 5 days 225 recombinant and 5 days urinary HMG. This is what I am giving. I'm giving you what I am doing. Is working well.
Okay, sir.
But urinary HMG 300, sir.
300 for a normal responder. And for patient who's a hyper responder, I'll start with 150. Maybe recombinant 150 for 10 days I'll keep giving.
Okay.
It depends upon the way you see the response. But in AMH more than 3 or 3.5, I'll never cross 225 ever.
If we give HMG or FSH more than 10 days, does the
No. It will be better, in fact. In case you hurry it up, you'll cause more problems.
Okay.
Be very gentle in stimulations. So I think time is 10. I have to also go for a small flag hosting somewhere. And you guys have many of the questions I could not take. You can put in the group because I had promised you all that we'll do it till 10 maximum. You all can go back to your chana bhaturas, and people wanted to have samosas. I had to get them out of the group in between. So that's it.
Can we get today's sessions recording?
No, we don't give recording of this one. These are meant for our alumnus batch. We don't record. So thank you so much for this, but we don't give. And I request all of you to take advantage of our this program which we are launching today. It's that virtual university. You can take advantage of that. Okay. Thank you so much.